Hi, everyone. My name is Dr. Jeanine Downie, and this is the Practical Dermatology Podcast. So, myself and several members of our Coalition for Inclusivity and Opportunity did lectures at the ASDS, and this is a synopsis of all of them. So, it will be me speaking tonight from Montclair, New Jersey. Dr. Mona Gohara will speak from New Haven, Connecticut. Dr. Anthony Rossi will speak from Manhattan, from New York City. Dr. Jacob Beer will speak from West Palm Beach, Florida, and Dr. Jane Yoo will speak from Manhattan, from New York as well. These are the cliff notes of our talks that we gave at the ASDS, and I would like to present my dear friend and co-chair, Dr. Mona Gohara, to go first.
Thank you so much for having us. It's a privilege to be here with Practical Dermatology. And as a follow up to our ASDS session that Dr. Downie really championed and put together. So I think we owe her a lot. Thank you. Thank you, Jeanine. I had the pleasure of speaking about implicit bias in dermatology and in medicine in general. And just kind of a general overview, we know that explicit bias are biases that we process, that we know about. Implicit biases are biases that we're unaware of. And I think one of the most important, so the one example is you can say explicit bias is I know I don't like the Lakers, or an implicit bias is I don't know I like the Lakers, but for some reason I don't like purple and gold, So that's kind of a easy way to put it together. But the important thing, and I really think the one key message that I want to relay is that we all have biases. It doesn't make us bad people, it makes us people. And I think that people associate having a bias with being somehow prejudice or somehow, you know, out to be oppressive, and that's a fallacy. It's very important for us to realize that we all have biases in some way, shape, or form, and that these then subsequently can play a role in medical care for us as doctors. First of all, for as people who are hiring people to be on our team, biases can play a role. Second of all, with the patient interaction, how long our interviews are, how we interact with a patient, what kinds of questions we're asking, what kinds of things that we assume about the patient all come into play with implicit bias. Third is in the interventions that we choose with our patients. What kinds of tests are we ordering? What kinds of medications do we give them? Can we diagnose them appropriately? For example, one big thing that in dermatology around implicit bias is that oftentimes we're not trained to see different to inflammation in different skin tones. So we may not be able to see that erythema in brown skin can actually be purple. So we may not know, or a darker tone or a different tone. So we may be our bias just because of our experience may actually interfere with our diagnosis. And then lastly, I know my time is coming up, is research in dermatology, what or in medicine in general. Our biases can play a role in research. So biases are a really insidious way that can very much have an impact in medicine and dermatology. And remember that we all have them. The key is to identify them because that is how we can overcome them.
Okay, that was fabulous. I'm going to go second, and what I talked about was misogyny and misogynoir, sexism and preserving equity for females. And one of my quotes that I talked about that morning was equal rights for others does not mean less rights for you. It's not pie. And the author of this fabulous quote is not known, but this sounds like something I would say. And then one of my dear friends talked about racism and sexism indisputably being burdens that affect the health, the justice, the safety, the economic, and the social realities of women and Black and Brown people in tangible and persistent ways. Misogyny is the dislike of or contempt for or ingrained prejudice against all women. And then misogynoir is a term coined by the scholar from Northwestern, Moya Bailey, the professor, and it's the unique combination of misogyny and anti Black racism experienced specifically by Black women. Now, these identities intersect, and as legal scholar Kimberly Crenshaw suggests, they multiply, which leads to oppression and a compounded form of oppression, particularly against Black and Brown women. And it does not just have to come from men, and it does not just have to come from other races. It can be within basically our race as well. So, looking at McKinsey and the World Economic Forum reported in 2024 that the closing of the women's health gap could boost the global economy by $1 trillion annually in 2024. And women's health for too long has been underfunded, marginalized, and misunderstood. And this is despite the fact that women utilize more than half of the global healthcare systems. This historic neglect is inequitable, it's unsustainable, and it's insufficient, and it has profound social and economic consequences. So, investing in women's health is not a moral imperative, it's an economic strategy. And if we were to do that, like McKinsey said, it would boost the global economy by more than $1 trillion. So then I talked about how women, just by our DNA, we have thicker dendrites in our spine for childbirth, so we can actually handle stress better than men. So the whole notion that women fall apart under stress, men commit suicide 75% more, they drunk drive more, they use drugs more, they commit violent crimes more, they abuse alcohol more, while women seek therapy. So we actually work better under pressure and dominate men in these areas, although the thought process is that we do not. I talked about racism in medical documentation with Black patients versus white patients, how white patients will be considered reluctant and Black patients will be considered resistant. White patients are requesting things, Black patients are demanding things. So I talked about the subtleties with words that are put into health records and how these can either describe or defame a situation. And then I talked about really women that ask for permission in our society to live. Unfortunately, with men, they're considered assertive. With women, we're considered aggressive because we still have to ask for permission because we're known as the nice people. And being direct, being open, being honest, and being blunt as a woman still does not go far in our society. And so basically, misogyny as a policy treats women as less than, and there's no laws that control a man's body in our society currently the way they control a woman's body in our society. And, just to the point, women's rights vary state by state currently in the United States of America, January 5th, 2026, where men keeps the same rights all across the platform. That is misogyny put into practice, and that violates the 14th Amendment. So at the end of the day, inequity is a crisis with deep roots, and sexism is a crisis with really deep roots. Misogyny and misogynoir. Women do not treat women well. Women interracial between Asian, Black, White, Latino, don't treat each other well. And then men, unfortunately, do not treat us well either. So all of this needs to change. Sexism and inequities need to stop. Misogyny and misogynoir need to stop. And I'm here for it to stop. I think that we're going to introduce Anthony Rossi next.
Thanks, Jeanine. Hi, I'm Anthony Rossi, practicing in New York, and I wanted to discuss building an inclusive practice for better patient care and what that actually means in today's world, and really focusing on something that is implementable in your everyday practice, and that's the identification of patient pronouns and gender identity, and how that is very important for us as practicing physicians to really understand, and why it's important for our patients. So, when we think of gender identity and expression, they're typically thought in binary terms, the male versus female. However, there's many people that fall off of this binary plane, and that includes transgender patients, trans women, trans men, as well as some that are non-gendered and non-binary. So it's really important for us as physicians who are taking care of patients in today's world that we create this inclusive environment, and we want to make patients feel inclusive. So a simple implementation that we talked about during our session was just creating your patient intake form to really embrace this and ask uh, explicitly, how our patients like to be identified, and that includes gender and what their pronouns are. So this really helps to bridge this cultural shift that makes things more inclusive. It helps to create an environment where our patients feel welcome and understood. And this can really help break down any barriers, especially for trans men and trans women or transgender and non binary patients to feel welcomed and to feel open to express their concerns, especially if it's involving gender affirming care. And as dermatologists, we often take a big part in gender affirming care along with our plastic surgery colleagues. And we really want to make sure our patients understand that they can talk to us about this. So, again, not every patient will identify as their cisgender or the gender that aligns with their sex at birth, and some exist on a continuity, including our transgender patients. So, understanding where these pronouns fall into place. So, he, she, they, her, they, those are all pronouns that are now used in everyday vernacular that we should be familiar with, and then we should be accepting of as well, and also encouraging our staff to understand and accept this and use these in very fluid speech. So patients shouldn't feel that they have to explain what this means, and our staff should be welcoming and understand this and use these pronouns correctly. One thing we also did talk about, which I think is really important in our session, is that things that we can talk about with our staff include understanding if someone does misgender someone, which can happen, or use the wrong pronoun, that's okay, and that patient, our staff shouldn't feel embarrassed, but they should just be open and willing to, apologize and learn from that, and also just create this environment where patients feel free to, discuss their needs, but also we shouldn't feel like this is a burden on ourselves or our staff.
That was excellent, Anthony. And Dr. Jacob Beer is next.
Thanks so much, Jeanine. I'm really excited to talk about a review of our conversation from our panel discussion in Chicago. So basically, I was talking about optimizing healthcare outcomes by addressing anti-Semitism. And anti-Semitism over the past few years has really become pervasive in our culture. And while it was previously thought to be more of a relic since October 7th, we've really found out how insidious and how prominent it is. And it's really seen on both sides of the political aisle, and it's seen much more than any of us would like, with the Anti-Defamation League tabulating over 9,000 anti-Semitic instances across the US in 2024, with a concerning rise in assaults being the primary instance. There's also a history of anti-Semitism in medicine that I believe is worth knowing for many physicians, with many conditions named after Nazi doctors who experimented on Jewish and other patients during this time. And in fact, in the early days of Nazi Germany, many physicians who were Jewish were relegated to dermatology because it was lumped in with venereal disease and seen as a less desirable specialty. And I've really experienced this personally as well, with anti-Semitic comments made to my staff, anti-Semitic threats made to my family, and anti-Semitic slights made even by well-respected members of our dermatology community made to me. And so then the question becomes, what can we do? And the first is to really be aware of any of these anti-Semitic tropes. And some of the most common ones are Jewish Americans having a dual loyalty to Israel, Jews being in control of the media, banking, or other fields, and depictions of Jewish people as vermin or animals. All of these are meant to dehumanize Jewish people and consider them other compared to other Americans and other groups of people. because if these people are dehumanized, then any sort of treatment is acceptable. The second thing that we can do is provide empathy and just compassion. And so oftentimes Jewish Americans can feel that their fears are brushed aside. And so it's important to really give this the same compassion and dedication that we would give to any sort of concerns or fears. And then third is to unequivocally condemn hate and violence. And so calls for condemning anti-Semitism are often met with calls to condemn Israel. And so it's really important to remember that condemning hate and violence should never really be contingent upon something else. It shouldn't have a contingency clause. We should be okay in our society being able to unequivocally condemn violence and hate. And so it's important that we all stand together. It's important that we address hate and prejudice in all of its forms. And it's really important that we recognize each other's humanity.
And last but certainly not least, I'd like to introduce Dr. Jane Yoo.
Thank you so much, Janine. So I was tasked about talking about Asian hate, which basically refers to discrimination and violence targeted towards Asian communities. We're not necessarily, one homogeneous community. We're quite heterogeneous, and due to recent sociopolitical factors, including COVID, there's been a lot of like fear and marginalization of Asian Americans. Does certainly does have deep historical roots, including some exclusion laws that have been in the past, and so this has been something that kind of like has shaped our societal views, and it is something that's ongoing challenges that are being faced by the communities. So when we talk about patients, and I think Mona really explained this well about implicit and explicit bias, um, Asians typically are stereotyped as being quiet, not really talking that much, or like, following all these treatment plans. However, I think having those assumptions can also lead to inequitable treatment, mistrust, and poor health outcomes. And not asking Asian patients those questions definitely can lead to poorer outcomes. Some of this has to do with like the language barriers. There may be cultural like misunderstandings and just lack of culturally competent services that restrict patient access. However, these experiences of racism and discrimination can cause a significant mental and health distress. And certainly within the Asian community, there's a lot of stigma around that, around anxiety as well as depression. And so having physical health disparities, in addition to the mental health disparities, adds just a tremendous amount of added stress. So, where do we fit in as healthcare providers? Well, I think we have a vital role in recognizing our own biases and also realizing that we can do things to foster a respectful, patient centered care. So, these are, some of the effective strategies include training programs on cultural humility, recognizing that Asian just isn't Chinese or Japanese, it's also a Southeast Asian. Um, People may be mixed heritage, and so we want to really engage the community and support, improve language access services to make sure that healthcare is fair and also inclusive. So, in summary, I guess Asian hate in healthcare requires a comprehensive approach, which all of you previously talked about. So it doesn't matter if you're Black, white, Hispanic, gay, trans, or Asian. I think we just need to be respectful of our communities and recognize that even though there are differences, at the end of the day, we're all human beings and we want to have, you know, uh, equity and trust among our communities and healthcare providers.
Perfect, Jane. Thank you so much. All of us, the bottom line that we're trying to get across to our colleagues and anybody interested in listening and learning and being a more effective, better doctor is that empathy is key to understanding people that are not like you, that are not similar to you, that are different than you. It's, like male doctors telling female patients that, what they're feeling isn't real. It's all of it. We need empathy as doctors to get to the next platform and to do better. So this whole thing, I think you all agree with me, is for people to understand more and to ultimately do better as physicians, because we can always reach a higher bar and a higher level and encourage our colleagues to, to be better also. So this is about being better. And I think all of your topics were absolutely excellent. And I appreciate all of you jumping on this podcast with me. And I hope people listen to it that need to listen to it. And I hope people listen to it that think they don't need to listen to it. I hope this is quite popular.